to the Spine and Nerve Podcast. My name is Dr. Brian Joves.
And my name is Dr. Nicolas Karvelas.
And we are going to dive into more facetogenic pain today. And so once again, thank you everybody for listening and watching and for all of your feedback. We really do appreciate your attention and hope that you're finding value, especially as we come back to this Back to Basics series where we're addressing some of the bread and butter topics of physiatry and pain medicine. So today we're going to cover a recent article that looked at interventions for the facet joint pain and specifically predictors that might affect how patients do with these procedures. So Dr. K, you want to give us a little bit more introduction?
Yes, and before we get into the article, I just wanted to do a real concise review of spondylosis with facetogenic pain being the primary pain generator before we jump into the article itself. I know we covered this last week, but just like I said, as a quick concise review here of spondylosis with the primary pain generator of lumbar facetogenic pain. So as we know, this is defined as a painful disease process originating from either the capsule, the fibrous capsule itself, and or the synovial membrane, and or the hyaline cartilage surfaces, and or the bony articulations of the facet joint itself. It is a common disease process, with most studies documenting around 15% of chronic low back pain being predominantly due to lumbar facetogenic pain. Although facetogenic pain can arise from acute injury, the majority of lumbar facetogenic pain is due to chronic repetitive strain and low-grade trauma that leads to consequences including distension or stretching of that fibrous capsule of the joint, as well as persistent accumulation of inflammatory chemicals, including substance P, which is associated ultimately with peripheral and central sensitization. And typically lumbar facetogenic pain presents as axial low back pain, and there are certain referral patterns specifically for the lower facet joints, which are the ones that typically are the most affected. That referred pain can radiate to the posterior and or lateral thigh, and on history and exam, patients are going to report low back pain that typically is not solely midline but lateralizes out to the side, and they will have tenderness to palpation over the facet joints themselves. So just wanted to do that quick, concise review before we jump into our first article, which is titled Predictors of Response to Medial Branch Block with Steroid, Radiofrequency Ablation, or Facet Joint Injections, published in Pain Management this year in 2021. So the whole purpose of this article was to determine an association between certain patient characteristics and patients' response to lumbar facet joint procedures. And you know, looking at that purpose, we were attracted to the article in the sense that, you know, for any procedure or surgical intervention, any treatment, it's good to have that those considerations in terms of patient selection, and not even in this case, I think, as much patient selection as it is the power of that knowledge and being able to have that education for the patient heading into the procedure itself. So in terms of the methods of this study, this was a single center retrospective observational study. It evaluated 100 patients between 2019 and 2020 at an outpatient academic pain center. These were patients with axial low back pain determined to be predominantly facetogenic pain based on their history and exam, including what we had brought up in terms of predominantly axial low back pain, lateralizing out to the side, tenderness to palpation over the facet joints, as well as some pain on provocative facet loading maneuvers. So the patient characteristics that were evaluated in this study included age, gender, BMI, history of prior back surgery, chronicity of pain. Specifically, they were looking at pain either greater to or less than 5 years of duration, medication usage, and then whether or not the patients had physical therapy prior to the procedure. The patients were evaluated at 3 months post-procedure. That was the time of outcome measure. And what they defined as non-responders versus responders. Non-responders in the specific study were defined as patients with less than 2-point change in their VAS score on a scale of 1 to 10, 0 to 10. So ultimately, the procedures that were performed in these 100 patients, the breakdown was 21 of these patients, interestingly, received a medial branch block with steroid, 55 received a radiofrequency ablation, and 24 patients received intraarticular facet injection with steroid. So the results will be fairly concise here because there was really two primary findings. Ultimately, 40 patients were classified as non-responders. So 60 patients had a good response, whereas 40 did not even meet that criteria of greater than greater than or equal to 2-point improvement on the VAS score, VAS scale. So the primary findings were that the positive responders were more likely to have a BMI lower than 30 relative to non-responders. So specifically, around 57% of responders had that lower BMI, whereas in the non-responders group, only 35% of patients had that lower BMI. So the other major finding, I'm going to come back to the weight in terms of obesity, and I'm going to come back to that in a moment just to drive home some points. But the other major finding of this study was that positive responders were more likely to have low back pain for less than 5 years relative to non-responders. So specifically, 71.7% of patients who had a good response had that shorter duration of chronic low back pain versus only 45% of the non-responders had that shorter duration chronic low back pain. So obviously, with all those percentages and numbers there, the take-home points being that BMI, so having a larger BMI as well as having pain for a longer duration of time were poor predictors or predictors of not having the best outcome with these interventional procedures.
Yeah, I think we'll just kind of start there on what they actually had as the outcomes, and then we'll do this kind of residency style and kind of have our takes on this study itself. But I think the results or the actual output of the study makes sense, right? I mean, I think these are things that we see on a regular basis, that patients that are heavier tend to not respond as well, and patients who have had pain for a longer period of time tend to not respond as well to these interventions. And I think, for the length of time, we can reference back to the chronification of pain topics, and we've kind of, I think, addressed that a lot recently in terms of if a patient has had this, and I don't know why they chose 5 years, but they chose 5 years. If a patient has had pain for more than 5 years, for this study, they did significantly worse than patients who had pain for a shorter period of time. I think that makes sense when we think about all of those pathways that we have discussed in the past. And and then obviously the weight issue has a lot to do, right? We have a lot of documentation that's been shown. I think the studies have been a little bit more clear when we talk about pressure across joints like the knee, but we can extrapolate that and use that for joints in the spine as well, saying that the more weight that you have, the more pressure that gets put on, and it's an exponential increase in the pressure across those joints. So it does make sense that they're going to respond a little bit less. Maybe even the authors have brought this up, the possibility that these patients might not have as precise of a procedure because of body habitus, and which obviously plays a role as well. But one of the things that I think I wanted to kind of talk about with this study, and I think Dr. Karvelas and I had brought up when we were discussing it after we'd read it, right? Obviously the title was very interesting to us, and it's recent and relevant to how we're addressing patients. But I don't know that the way that this study was done necessarily would have been how I would have ideally liked it to be. I think that they had patients that they're following up at 3 months. They had patients treated with medial branch blocks with steroid, which I know that obviously is done, and some patients respond really well to. But I think if we're looking at that time frame, the 3-month mark, if we would have had patients that were treated with radiofrequency ablation, and therefore had met the criterion for treatment with radiofrequency ablation with 2 medial branch blocks with greater than 80% relief, that we would have got more interesting data from my perspective. I'll leave it there. Thoughts?
Yeah, no, I agree. I mean, I think as we said in the beginning, I think the intent of the study, was great in terms of continuing to give us data in regards to, how to best educate and select patients for these different procedures. So, it adds to that data pool. But yeah, I agree. I think the duration, exactly when they did the outcome measure, and then also having the mixed bag of interventions, which we know, especially the medial branch block with steroid, is that going to give us 3 months of benefit? I think the data is a little conflicting there, and so yeah, I think the mixed bag and the exact timing of the outcome measure was potentially compromise the results a little bit, but so as I mentioned, I wanted to dive into the obesity just a little bit, but before I even do that, I just wanted to mention a couple of things. So in this, there was a lot of outcome measures they looked at. So we brought up BMI and the duration of pain as the biggest outcomes that we saw definitive changes in. But there was also history of back surgery as well as having physical therapy before the treatment. And both of those trended, not quite as significant results, but they trended towards being, having an impact on these patients. So obviously, having a history of back surgery was a negative, had a negative impact on whether or not patients responded to these procedures, whereas having physical therapy before the treatment had a positive effect on whether or not they had a good response.
Yeah, and just as a side note on that, they were both fairly close, we said trending in the direction, right? They were fairly close to actually meeting clinical relevance. So in an appropriately powered study, I think both of those probably would have also shown to be appropriately predictive.
Yeah. So I'm going to talk about the obesity, and then I think Dr. Joves and I will do our final takeaways from the implications of this clinically for us and for patients who have facetogenic pain. So quickly to emphasize the obesity finding, and this adds to our impact when we're educating patients on weight optimization. And I really try to utilize that term weight optimization. I stay away from the term obesity and I think, I don't know, I just think that resonates a little bit better with the patients, and so when you're saying, hey, if we optimize weight, if we have weight optimization, that's going to put less stress across the joint, versus just saying, hey, if you lose weight, or if we improve the obesity, that may have a different impact on the patient. So I really try to use that weight optimization term. And with the weight optimization, like Dr. Joves brought up, it makes sense that obesity would worsen chronic low back pain because increased weight would increase stress on the facet joints. But there's growing research as well demonstrating that the impact of obesity goes beyond just the mechanical loading effect. So there's mounting evidence that obesity increases systemic inflammation in and of itself, and can be linked to worsening chronic pain. So as an example, there was a study published in the Journal of Spine in 2018. It was a retrospective review of 76 patients that found that even after adjusted analysis, there was a significant relationship between physical inactivity and obesity with markers of systemic inflammation. Specifically, in this study, they looked at ESR and CRP, and the increase in these markers of inflammation was correlated with chronic low back pain. So essentially, the take-home point being that if we can optimize weight, this can result in decreased systemic inflammation, including these levels of cytokines and inflammatory mediators, which should result in an improvement in overall pain. So in addition to that mechanical load on the joints, we have this systemic inflammation as well. So just as a final thoughts in terms of this study with the BMI and the chronicity of pain. And Dr. Joves, I like your opinion here if it differs from mine, but I wouldn't say that if you have a patient who has a BMI greater than 30 and who's had pain for longer than 5 years that we shouldn't be doing facet procedures on it. I wouldn't have that be the conclusion of this study. But what I would, this study and other studies that are going to continue to be done in terms of predicting outcomes for these procedures, we take that into consideration when we're counseling the patient and when we're thinking about the next steps after our specific procedures. So for example, if we have a patient, who does have a really high BMI, upper 30s, and maybe they've had pain for, over 5 years, and we do a medial branch block on them, and they don't have, a great response, or they do okay with medial branch blocks, and we do a radiofrequency ablation, they don't have a great response. In contrast to maybe a individual who's really fit and has pretty clear facetogenic pain, or at least we thought so on exam, and maybe their pain's only been going on for a year or two, and like I said, they're relatively fit. If we do facet procedures on them and they don't respond, then I'm really taking a step back and saying, okay, well, maybe we're missing something here. Let's reevaluate, re-examine, think about other causes, versus with the scenario I brought up in terms of someone who's had pain for a long time and potentially a higher BMI, just keeping that in the back of our mind that maybe their lack of response wasn't so much due to the fact that we don't have the right diagnosis here, but more so that we need to optimize these other things, and that's where we can educate. And of course, we keep our mind open to other diagnoses, but we educate the patient that, look, if we can improve these other things, and then potentially we can have better responses with our procedures. Going back to the weight optimization and educating the patient on the change in the mechanical loads, the change in the systemic inflammation. But also the other thing is that if we have these patients who've had pain for longer than 5 years, or long duration of their facetogenic pain, and we don't quite have that response we're looking for on the facet procedures, those are those patients that, as we've talked about in other discussions, maybe those are the patients we really start to think about neuromodulation, maybe in the form of peripheral nerve stimulation, because we understand that our suboptimal response may be because of that central and peripheral sensitization, and so we need a therapy that's going to have more of a direct effect on that.
Yeah, and I think it's really hard to discuss weight optimization for patients with back pain. I think all of us who treat patients with back pain have seen patients try to have these conversations, tried to educate them appropriately, and the answer from the patient is always, well, if I could just get my pain better, I can move more, and that would make things better for me. Which we've covered before, and I know we've talked about, and it's not exactly the response that we believe is true. Obviously, we want patients to move, to do the physical therapy, to do the exercises, and that will lead to improvements in their pain. And and then there's the side note of, is that movement component really the most important thing for weight loss? But I think we're not as kind of strong with those decisions as, say, orthopedic surgeons or spine surgeons, right? I mean, I know that in the orthopedic literature, it is very well documented for knee replacements that if patients are over a certain BMI, that they do significantly worse with knee replacements or any joint replacement. And many surgeons stick to that, right? Where they're like, nope, if your BMI is 40, not replacing your knee. You got to lose weight before you do that. Or spine surgeons that will tell patients that they're not going to do a procedure on them until they get their weight down. And obviously, our procedures are different than those interventions. They're much less invasive. Our goal is to use our procedures to help the patients along so that they can do those types of things. But maybe this is spurring another conversation that we need to have on the idea of weight optimization. Side note, my wife has been on a biohacking journey recently. and she's been listening to a ton of podcasts about weight optimization and different dietary interventions. My personal background is in nutrition. My master's thesis was written in nutrition, and so I think that there is a lot to this, and it's not always as easy as counseling a patient or talking to them about this or that to be able to optimize their weight. I think especially in the setting of you brought up chronic inflammation and chronic pain, and then we have this weight optimization thing that we need to work on, because obviously we know that patients are going to do better if they're in a better physical place. Anyways, that was a long side note about it, but I think it's a much harder conversation to have with patients than just saying, okay, well, you need to lose weight. I think we'd all like to lose weight a little bit. Maybe not you. You'd like to gain weight, but most of us would like to lose a little bit of weight, and it's not always that simple for patients.
Yeah, it's definitely that weight optimization, that lifestyle optimization, that's definitely a journey, and that's where we as healthcare providers come in to help the patients navigate that, because that's not a one visit deal. That's a multiple years approach that we're trying to create and optimize approaches to it. But
it's life change.
Yeah. All
right. So, Article 2.
So real quickly to wrap up here, we always emphasize how important diagnosis is. We can do a procedure or whatever treatment perfectly, but if we don't have the right diagnosis, it's not going to matter. And so anytime we're talking about facetogenic pain, it's important to bring up kind of landmark articles in terms of diagnosis. And so obviously, as we've brought up, unfortunately there's no specific history or physical exam maneuver that's really pathognomonic for lumbar facetogenic pain. So we do rely on our image-guided diagnostic procedures, and in the past there was a question of what was better in terms of predicting both optimizing our diagnosis of facetogenic disease as well as response to radiofrequency ablation, and the question was medial branch block versus intraarticular injection. And so one of the big studies looking at this was a study by Dr. Cohen and colleagues published in 2015. It was titled Medial Branch Block or Intraarticular Injection as a Prognostic Tool Before Lumbar Facet Radiofrequency Denervation, a multi-center case control study. The purpose was simply to compare the diagnostic value of medial branch block versus intraarticular injection prior to radiofrequency ablation. It was a case control study at 4 different institutions evaluating patients treated with radiofrequency denervation that resulted in greater than or equal to 50% improvement in pain. And ultimately, they had 212 patients who received medial branch block and 212 patients who received intraarticular injections prior to radiofrequency ablation. And what they found was that in the patients who underwent medial branch block, 70% of those patients had greater than or equal to 50% improvement in symptoms with radiofrequency ablation, in contrast to about 60% of patients who underwent intraarticular injection experienced greater than or equal to 50% improvement. So not drastic difference there, but it was statistically significant. And after they did a multivariable analysis, they found that performing medial branch block was associated with radiofrequency denervation treatment success with an odds ratio of 1.57.
Yeah, and thanks for bringing up that article, because it is one of the important articles to think about, and it has guided the Medicare national coverage determinations, for proceeding with radiofrequency ablation. Previously, you could use intraarticular facet injections. It is no longer one of the things that is considered diagnostic to move forward with radiofrequency ablation, and so this was one of the articles that was, I think, a big part of that change happening. But I think most importantly, one of the things that you brought up is that, and I wanted to bring it up earlier in the study, or in the first study when we first brought it, but I think it's good to end with, because as we're thinking about lumbar facet mediated pain, really understanding and knowing that the history, the physical, there's nothing that is pathognomonic for facet joint pain, right? These diagnostic blocks that we do are the best thing that we have to be able to truly identify that the facet joint is what's helping or what's causing the pain for the patient, and that's where our attention should be directed when we're trying to make interventions for the patient. Right? Everything. Obviously, we take a history. It sounds like this. We can do a physical exam. Sometimes we talked about last time. Sometimes you can get pain with palpation or with facet loading. Sometimes you don't. None of those have shown in studies to be pathognomonic for the disease process. The only thing that's really been shown to be truly diagnostic for identifying facet joint pain is utilizing diagnostic interventions to help with that.
Yep.
All right. Well, I think that's all I've got. You got any closing remarks as we finish up our podcast today?
No, that's it. Thank you, guys.
All right, guys. Thanks for listening, and stay tuned for those legal disclaimers.